And Evelyne's going to look at the geroprotector side of that. So what can we do to improve our health and to optimize our future health at this time in 2025? So Evelyne, if you come back again. Thank you so much. Thanks.
And they still get the music. It's nice. Lovely again to be here. This part is really focused now on, like Martin mentioned, a few of the things that we potentially could do for our patients or for us in order to extend the health span, optimize it. But with a big but disclaimer, those are still things that are in trials or showed preliminary positive data in trials. Still, it's very important and interesting to learn how what was proved or not. Okay, so the topic today is healthy longevity drugs, particularly repurposed drugs and or some of the substances marketed as supplements. Which one of those can actually be applied in healthy longevity medicine? And again, I will probably not show anything extremely surprising. You have all heard the names of the drugs, but hopefully we'll bring a little bit more of a structure and an order to it. So right now, we know that we repurpose drugs for diseases. Clearly, we use different drugs, not only for one disease, but we repurpose for other types of disease. Diagnostics has advanced significantly in oncology, for example, in my field. We have very good ways to repurpose drugs, or at least to map a patient with transcriptomics, metabolomics, to see if maybe some other drug would actually work on a patient that is in palliative situation. However, in general, the repurposing of drugs is nothing new. We are just trying some drugs that are safe and proven and used for one disease into other disease. Now, there are still a lot of those that are not being touched. There are very good data sets on repurposed drugs where you could see that AI is already suggesting what are those drugs potentially good for as well. But the question is, of course, what do we then use that is validated in mammals for health span, and how we do that? So I think we heard a lot about lifestyle, and we know that it works if done properly and is personalized. We also know that there is also a specific point of our basic genetics and omics that is non-modifiable so far, and it has an influence. But how about pharmaco interventions? How about things we can actually take in different routes? Another point is, as we heard many, many times, aging is multifactorial, and aging is the root for many, many chronic diseases, age-related diseases. So logically, in reverse, if we target some of those diseases, we somehow also target aging. That was the basic understanding of why we would look at different drugs that are applied in those typical age-related diseases, metabolic diseases, endocrinologic diseases, dementia, and many, many others. And of course, age-related syndromes such as obesity syndrome, metabolic syndrome, and others. And once hallmarks of aging were published and then updated, we also had a little bit more of a systematic approach to what we are looking for in terms of the efficacy and mechanisms of actions of those drugs. So which of the hallmarks are being targeted and tapped by specific drugs. And as we also heard today, a lot of those drugs work on different hallmarks of aging. Now we'll show one of those drugs that you all know later on. We have a lot of challenges. You cannot just trial repurposed drugs on anybody. You have to define your population. But even before you go there, you have to trial on some models. Hopefully, very soon we can move away from some of the models that are being used right now, but so far we have mostly the animal models, and they are just particularly nice, but not really translatable to humans. But I think the most prominent, massive global project that allowed to trial a lot of drugs for health span in mice was the ITP that I would like to talk about for a moment. And there is this concept of the size versus lifespan relationship that is actually measuring this longevity quotient. It says, as you can see here, that there is some correlation of your size and body weight to your longevity. It seems like the bigger, the more. Although it doesn't really go this way, because if you then apply it to some of the animal models that we are using, and you go by the longevity quotient, the actual one that is predicted is showing that some species live much longer, such as the naked mole rat that is being used a lot in the studies. So there is this network from the National Institute of Aging called ITP, Interventions Testing Program, which you might know. ITP is a great program where anybody of academia can suggest a drug to trial on different mice, different genetic models of those mice. They exhibit also different characteristics, basically a trial population. And it's a very rigorous lifespan and health span measurement of those animals, but mostly, of course, lifespan is that what is most objective in that case. Once they die, they die. But it is a validated tool for aging research. Still, it's only in the animals. So, as I mentioned before, those mice are different. They vary genetically. They vary from the characteristics. And there are then 3 different independent sites of the validation of those experiments, so that it's very robust, traceable, and then at the end, the statistical design is good. And the list of all the drugs that we studied so far, you can see here. Most of them we know, and some of them we will now discuss. And if you are doing research, consider this is a very important and powerful tool for you to validate or to gain insights. But by far, it's not complete. Now, what was shown to be most successful so far in extension of lifespan in mice? Number 1, sirolimus, rapamycin/mTOR inhibitors, acarbose, glycine, estradiol, estrogen, and SGLT2 inhibitor canagliflozin. Pretty impressive numbers. So, for example, when you look at rapamycin, it was somewhere around 20 to 25% of lifespan extension in the mice. But even estrogen, estradiol, 19%, quite intense. Acarbose, 22%. Acarbose, a very, very inexpensive, old drug with limited side effects. What was most unsuccessful? There is always the list of the top and the blue ones. So the ones that just did not show lifespan extension, and then again, it doesn't mean that they are not good potentially for health span, was resveratrol, metformin, complicated discussion, and curcumin, and then several others like some of the fatty acids, statins, ACE inhibitors, and so on. Now, let's talk about the hits, the rapamycin, for example. So, rapamycin comes from the island, that's why the name. It's come actually from a plant, it's a toxin, it's an immunosuppressant, and very, very, very widely used in autoimmune diseases and cancer patients. And it's a very, very potent mTOR pathway inhibitor. There is a discussion whether it's only mTOR A and B, or 1 and 2. It's a different discussion. Overall, definitely what it does clinically, it mimics the fasting or mimics the caloric restriction in people. And also, on another level, it activates the catabolic processes where you actually grow and repair. And it also mounts your immune response. So actually we saw, and we'll talk about it in a moment, how your immune system is on one side immunosuppressed, but on the other side, you respond to the vaccine, so to immunomodulation much better. So it's a little bit complicated. That's why I will just go directly to the point, saying what is important for us for the health span. mTOR inhibitor in the studies on the tissues showed decelerated cellular aging, and also it showed a reduced anabolic signaling, which is important. So muscle building and stuff like that is very important. And it also works very strongly on autophagy and proteostasis. So once again, hallmarks of aging that are important. it shows also that probably metabolically, people have like an, MRV, metabolic rate variability, where you are actually increasing your adaptability to different parts. Have there been many trials on humans? Sadly, no. I think one of the most famous trials was a trial conducted at that time in Novartis by Dr. John Manig. He's one of the leaders in the field, I believe, especially in trialing mTOR inhibitors. And the study was looking specifically at a population that is 60 plus, people with flu, and they got vaccination, and the response to vaccination was measured. The study almost reached the end point, sadly not fully, so there was no follow-up with the phase 3, but it was almost significantly impactful. So at least we saw definitely very clear clinical impact. And then recently published was also a trial called PEARL, where also Professor Evelyne being involved, where people were taking rapamycin voluntarily on their own base and then reporting and mapping their clinical responses to it in a digital way. So there were benefits, as we spoke before, clinically regarding immunology, brain function, caloric restriction, but there were also side effects. Now, how did it look in mice? In mice, of course, we can measure lifespan much easier, so lifespan was extended, as we mentioned before, up to 25%, but we couldn't really see very well how much of the health span was improved. Apparently, some of the metrics were better. Cognition, agility, you weight less, you have more energy, and immune resilience was better. So to be continued and to be seen. What we actually know is those clinical things are happening and visible, but we cannot really still figure out exact the mechanisms and what are the dosages and what are the frequencies that should be used in order to, on the one side, prevent an overaction in side effects, and at the same time knowing that the side effect, for example, the inflammation that is causing ulcers, is necessary for the drug to work. So it's a little bit of a fine print here, but very interesting part. The second family of medications, SGLT2 inhibitors, are super interesting, and in many, many scans for repurposed drugs, not only in the ITP studies, they have been shown as a very, very potent candidates. Old drugs that are safe are used in diabetic patients a lot. Even with a reasonable kidney function, it's still safe to use. It's actually something that we've seen in canagliflozin, and right now also dapagliflozin and others are also being trialed. What it does, it actually just blocks the reabsorption of glucose in the urine, so more of the urine is getting out. This causes quite a bit of side effects, urine infections, but overall a safe drug. And what it also does, it has an impact as an inhibitor on the mTOR signaling, and it's activating AMPK kinase, something that we see specifically in metformin as well. And of course, lower blood glucose, less spikes, better insulin sensitivity ultimately leads to an overall better health span. And so studies that were looking at specific endpoints that are related to the health span, such as cardio prevention, such as diabetes prevention, renal protection, all of them, of course, showed that SGLT2 use led to better outcomes. Acarbose is, I think, super interesting. Once again, it's a drug that we don't use so much anymore in the clinical practice. It's relatively cheap. It's an oral glucosidase. It blocks your absorption of glucose in the gut, and therefore also leads to the fact that the glucose spikes are being a little bit paced, and you don't get your peaks. Insulin resistance goes down, and so on. All of those metabolic benefits are there. It's also partially linked to the pathways of the IGF-1, which, as we know, is very strongly correlated to growth / health span. And we use it a lot in diabetic patients who, for example, do not have yet the need for very extensive and strong drugs, or where we know that main source of sugar is actually coming from the food. Apparently, acarbose might also be involved partially in mTOR inhibitor pathway, and therefore reduces the anabolic signaling. Not very sure if it's increasing the catabolic one, but definitely it's also working on the proteostasis and autophagy. One of the most favorite parts here that I would like to show is the estradiol, 17-alpha estradiol. Some other forms are now being trialed as well, but this one is very interesting, specifically because we have seen that it works on all of the hallmarks of aging. And in mice liked it. They also lived longer, especially not only the female mice, also the male mice, but that's not very recommendable in humans. And of course, estradiol has a great role in aging. So HRT, promotion of HRT for the right population, perimenopausally, not postmenopausally only, and probably for a prolonged time and not only for young patients is important, as finally also confirmed by the FDA just a few days ago. And then we have a few of substances that are now available as supplements, which is, for example, the glycine. Some people take it for glucose control, some people take it for better sleep, some people just take it. And it's interesting. So mice also lived longer, about, I think it was about 10% of life extension. We just know that in humans, when the glycine levels are low, people are much more prone to have also insulin resistance and higher inflammation, which may or may not be connected to obesity that usually results in it. And then we have protonine. Basically, this is an element that is found in various supplements. So, you know, you can see it in different mixes, and activation of the NRF factor 2 is here of importance. Male mice especially lived longer, and it was also very supportive in terms of inflammation, chronic inflammation, and cognitive function. So you also find it in Bacopa minieri, for example, or ashwagandha, all of those supplements that are very nicely used in neurocognitive problems. Metformin, one of the drugs that is very, very often discussed, is a very successful and nice drug for diabetes. FDA approved it, and it's being used widely, even though we know that it inhibits AMPK. Still, probably other mechanisms are not that well established. And of course, the same mechanism, glucose down, insulin resistance down. Overall, we know that probably it also works on the mTOR inhibitor, so there is a lot of repetition here. In the same way it works on autophagy, mitochondrial health, and inflammation. The most important and the most famous study that is hopefully gonna start at some point is TAME, targeting aging with metformin in humans over a long period of time, with measurements of endpoints that are crucial for this, for example, IGF-1 and so on. Still not going, so that's why the question is, should we or should we now take metformin? I believe the answer is we don't know. What we know is that if a person has insulin resistance or has a metabolic syndrome, prediabetes, it's definitely worth considering as a dual target for aging and for that specific disease, maybe with a little bit of a lower threshold. And then, of course, one needs to consider if the patient is above 60, 65, probably that's a better population to give it to, and the muscle mass needs to be maintained and not too low. Sarcopenia is a danger. And last but not least, GLP analoga. Those are the first drugs that were published and mentioned by pharma companies as potential longevity drugs. It was a big milestone that I think we were all happy about, to hear that big pharma is now also interested very much in the field. And GLP agonists of different kinds have, of course, led to a variety of positive side effects that are related to the health span, from weight loss through reduction of inflammation, through reduction of cardiovascular risk, renal risk, and now also very good studies in dementia patients of Alzheimer type, vascular dementia. For physicians, it all makes sense, because once you reduce one of the main risks, which is prediabetes, which is your kidney impact through it, which is your liver fat, and so on, all the things that go with the metabolic syndrome / obesity, you of course improve your health span. We have now new generation of the drugs, right? We have GLP-1 agonists also that are coming with GIPs. We have different success rates in terms of weight loss for each of those, and also a little bit of a different range of side effects. But overall, it's clear that the endpoints are mostly met in all of them, which go with the reduction of the clinical obesity and inflammation in those patients. It's also acting on the brain on a little bit different way and through different pathways that are not directly linked to obesity. So, for example, it not only reduces the appetite and the food intake, but also activates some of the vascular pathways there, and helps the brain to be active. So it goes beyond diabetes, it goes beyond obesity, although it is actually approved for that. But thanks to those many studies that were conducted, we now can say, okay, some of the clear endpoints of health span are being met in that situation for those specific patients. I think some of those main studies that are worth mentioning is, for example, the LEADER study. It was one of the first studies in New England of Medicine in 2016. Showing that those drugs have a very strong effect on cardiovascular risk reduction, including stroke, of course. And then the REWIND study in Lancet showed exactly the same, which was also very interesting, but also helped the kidneys to recover a bit. Very strong predictor also of mortality and morbidity. And last but not least, the tirzepatide SURPASS-2 trial with outstanding results, also for the brain, cardiovascular, and cognitive function. Patients will ask, should we take it? Should we take it not only for weight loss? There are slim patients who hear about GLP-1s as longevity drugs. The question is, should we not? Well, again, question should be answered with, we don't know. Definitely there are some patient population who should not take it if they're already slim, if they have low muscle mass, if they have kidney impairment and so on. That's definitely not ideal. There are side effects. Also, if the patient has already a high metabolic rate and is keeping the body actually in a reasonable state, slowing down the metabolic rate with GLP agonist probably is not the greatest idea. So it's very important to guide the patient and to have a system in place around it to reduce the side effects, muscle mass building, actual psychological training at the same time if there is a problem with overeating, and very safe and stable weight loss without rebound that is mostly resulting in the rebound of visceral fat rather than muscle mass. And of course, I'm probably preaching to the choir, but if there is anybody who is considering using repurposed drugs, the first checklist is the same like with any other drugs. It's the FDA checklist. For whom, which dose, what is the frequency, and where do we find evidence for that specific patient? Is it recommendation level A, B, or C? And always look at the additional things that you can find. There will be people who have pharmacogenetics done, and in the report you might find that they are actually super metabolizer of the drug, or the other way around, and you might overdose. And last but not least, the program all around those repurposed drugs has to be in place as well. You might harm if the typical side effects are not regulated. Ulcers leading to bleedings, leading to, we all know what it can do for ending in the colon. Further on, muscle mass loss, which goes with every weight loss, but should be then at least very, very strongly addressed and explained to the patients. And then other side effects that might have been reported, at least for the awareness, pancreatitis, and so on. Wonderful. With this, I would like to end, and thank you for your attention. Thank you.
Thanks very much. very much. That's great. So we'll just take a couple of questions?
Sure.
For the panel? Okay.
I will stay.
You stay?
I will stay.
Don't run away. Okay, so how far away are we from knowing which of these drugs truly make a difference in everyday life?
I wish I would say not too far, but a phase 3 clinical trial for HealthSpan is a little long. Well, probably at least 2 years, because you want to have a washout phase, interaction, and then take it away and see how long the effect might last after you took away the drug. And this doesn't even include the frequency and the dosage. And then it's expensive, because you want to map as many biomarkers of aging as possible and not to look only at the very general clinical endpoints like weight loss or visceral fat loss. So I think I cannot make predictions on prognosis, but I don't think it will happen tomorrow.
Your opinion on the keto diet?
My opinion on the keto diet. Very good evidence that keto diet is helpful in patients or infants with epilepsy or with brain problems. I think I would like to see more evidence whether keto might be actually helpful for health span in healthy individuals. I do not recommend it to my patients.
And we'll just take the last question here.
Sure.
Isn't a simple case for acarbose, SGL2, metformin, just glucose lowering impact on aging? Being on the low end of blood glucose without hypoglycemia is best?
Yeah, it's a good question. So probably not, right? So acarbose, SGLT2, they have other properties, mTOR inhibition, AMPK. The general clinical part is, of course, lowering the glucose, but not only. So definitely with mTOR, it works on inflammation, on immune modulation, and so on. Being on the low end of blood glucose, well, not, definitely not. That's very personal. You should not be hypoglycemic. That's not good for the brain or for the muscle, but one should not be hyperglycemic for prolonged time, especially at night, and without too many peaks. So, yeah.
Brilliant.
Great. Thank you so much.
Thank you. Okay, thank you.